unlocking the power of public health data. We have to unlock that power, harness it, use it, and change people's lives.
If we want to get to universal health coverage, we got to start with primary health care because that's where 70% of the response is going to be.
Taking care of our future generation. Yeah. We have to start from us. We have to start this kind of advocacy.
Hello and welcome. My name is Betsy McKay. I am a senior writer for the Wall Street Journal, covering public health and medicine. And I'm speaking with Ashish Jha, who probably needs no introduction, but we'll introduce him anyway. He's White House COVID-19 Response Coordinator and on leave as Dean of the School of Public Health at Brown. Ashish, as you probably know, is a globally recognized expert on pandemic preparedness and response, global health policy, health costs. I think I've called you a couple of times about health costs and the effects of climate change on health outcomes. So thrilled to have the chance to talk with you, and it's been a while.
It has been a while.
So Ashish, before we talk about the future, which is kind of what we want to do in this next half hour, can we talk about the present for a minute? So the emergency is over, but where are we with COVID? Are we still in a pandemic? Is COVID endemic? I mean, people are doing all different things. I see people are measuring CO2 levels wherever they go, and others are don't even own a mask anymore. So Where are we?
Yeah, so good question, and good afternoon, everybody, and thank you to the Rockefeller Foundation for having me here. So we ended the emergency about 2 weeks ago, and I want to just take 30 seconds to explain why this was the right time. The public health emergency is not meant to be a symbolic thing of is COVID important or not important. It's a very specific set of policy tools, largely focused on the healthcare system, largely around making sure we have enough healthcare capacity to manage. And basically 3 months ago, the health secretary decided that we were at a point, especially after the experience of this past winter, that we were at a point where those emergency tools were no longer needed. And so he made a decision, and the public health emergency came to an end. It does not mean COVID is gone. We obviously know it's not. Obviously, we are in a better place. 90 to 95% of Americans have either been infected or gotten vaccinated. It's probably closer to 95%, so most people have some immunity to this virus. The challenge, and this really gets to kind of how we think about this moment, is while right now, today, we're at some of the lowest levels of infection, certainly some of the lowest levels of hospitalization deaths we've seen in the entire 3 years, there is nothing about this virus that should give us confidence that we will not see another resurgence. The virus continues to mutate and kind of have evolutionary drift at a pretty constant pace. We're seeing the emergence of new variants with some frequency, and we may very well, obviously we all hope we don't, but there is certainly a risk that we could see a very different looking variant that could really do a lot of escaping of our immunity. So the challenge for us, I think, inside the administration is both to acknowledge where we are. Most Americans have gone back to kind of their regular ways of doing things, but also make sure we are ready if such an occurrence happens, that we are ready for what will be probably cyclical surges, but then also that unlikely but potentially much more consequential event if we get a very different looking virus.
So there has been some criticism in public health circles that removing some of these emergency measures and stepping back on restrictions and protections is leaving the most vulnerable at incredible risk. So what do you say?
How do we think about that? Yeah, so look, there's just a lot of conflation and confusion about a lot of issues. So people often say, the ending of the public health emergency means free vaccines and treatments go away. They don't. Like, you can go out today to a CVS and get a COVID shot and get your Paxlovid. It'll be free to every American. Those will eventually go away, not because we ended the emergency, but because Congress stopped funding this. And so we can't buy vaccines and treatments without money. I mean, that sort of goes without saying. So even if we had kept the emergency on for the next 5 years, free vaccines and treatments would have to come to an end over this summer into fall, because that was really driven by the fact the US government was buying money. In terms of the most vulnerable, here's what we know. First of all, most people, including most immunocompromised people, do still benefit quite a bit from vaccines. And we have terrific treatments, but not enough. So we launched recently this project, NextGen, which I'm happy to talk more about, which is actually focused on making sure we can get new monoclonal therapies and other treatments that will be useful for vulnerable Americans who may not be eligible for current treatments. We continue to sort of focus on, like, we're down about 130 to 150 deaths a day. How do we get that number lower? Most of the people who are dying are not up to date on their vaccines, or they're not getting treated, or are profoundly immunocompromised. We obviously want to figure out what we can do to keep driving that number lower.
So now let's talk about preparing for the next one, the future. Yep. The first thing I want to know is, what do you think is the next threat, the next biggest threat? What are you most worried about?
From an infectious disease point of view? Or?
What disease is coming after us?
Well, I wish I knew. If I knew, and if I knew the timing, I'm not sure I'd be sitting here.
You need to stay in your job for a while, and they'll change the name of it.
Look, I think one of the things that we have learned over the last 20 years, if you just follow the data, is the frequency of novel outbreaks in human populations has been increasing. We can talk about why that is. Climate change is certainly one part of it, broader environmental changes. And then those outbreaks of novel pathogens, like pathogens that humans have not seen before, are becoming global much faster because we live in a highly globalized world. And those two factors together is very much driving us towards more and more outbreaks. And that means I have, obviously zero ability to predict when the next thing will hit. People often have this mental model of, well, this is the worst in 100 years. Does this somehow reset the clock for another 100 years? It doesn't work that way, right? The risk that was here 5 years ago is still the risk today. And so we just have to do preparation. Obviously, we're paying very close attention to avian influenza, not because we know that's going to become a real human threat, but obviously that's something that's very consequential. We're constantly monitoring around the world to look for emergence of new pathogens. I think the biggest lesson of the last 3 years is that in some ways we got to get out of the prediction business, and we just got to get into the preparation business. I have no ability, even with this virus, which I feel like I have spent basically every waking hour of the last 3 years thinking about, still hard for me to predict exactly what's going to happen with this virus in 3 months, 6 months, or a year from now. And so mostly the key is, let's stop worrying excessively about predicting. Let's make sure whatever comes our way, that we are as ready as possible.
So let's not put any money in prediction, or are you saying just not rely on it so much?
I think not rely on it so much. I mean, it's fine to do predictions, and there are people who will do predictions, and there are people who are predicting what will happen with SARS-CoV-2, and I talk to those people, and I hear their views. But I guess the point is, there is enough uncertainty around the predictions, and the consequences of being underprepared are so substantial that the right answer is just be prepared for a whole variety of scenarios, and you'll be better off.
So let's talk about how well or not well we are prepared. Let me just ask you a broad question first, and then we can dig into questions on each aspect of it. But looking broadly, how are we going to come out of this pandemic? How prepared are we? As an A, a B, a C, or we just got through this pandemic and we're not any better prepared than, or maybe we're worse off.
Yeah, there is this narrative I hear from people who say we're even in worse shape than we were 3 years ago. I think that is just plainly wrong. We are in better shape in terms of being prepared for the next one than we were 3.5 years ago. And let me make the case for that. So, and the bottom line I'm going to give you, Betsy, is we are better prepared. We're not prepared well enough. We just have a lot more work to do. So how are we better prepared?
So that's a B minus.
It depends. I mean, some places I've worked we grade on a pretty significant grade inflation, so that might be an A.
Okay.
I'm kidding. That's a joke. It is not. So let's talk about how we're better, because I do want to just tick on those things because I think it's important. One of the ways in which we're way better is our surveillance capability. We have developed a national wastewater surveillance system in the United States. We've got wastewater surveillance happening in other places. We have traveler genomic sequencing. Genomic sequencing in general has gotten dramatically cheaper and better in the last 3.5 years. We have much better eyes on what is happening with pathogens around the country and around the world than we did 3.5 years ago. That's huge. That will make an enormous difference the next time we see something novel. Or even if we see something not novel, something we've seen before. Our ability to get an assessment of where is it in the country, how much of a problem is it, will be very, very different. So that's better. I think we have proven that mRNA platforms work, and we can build vaccines very, very quickly. The mRNA vaccine platform is not just good for COVID. You are going to see over the next 5 years a whole host of new vaccines coming out. Again, we've got to go faster and got to get more equitably distributed around the world. There's lots of work to do, but our ability to build vaccines quickly has gotten much better, and we just got to keep going on that. And there's a lot of science, but also a lot of other kind of work to do. So those are, and similarly on treatment. So a lot of things, our tests, treatments, and vaccines have been dramatically improved over the last 3.5 years. But let's talk about the things that are not better. I think, for years I used to think about pandemic preparedness and think about pandemic preparedness plans. And most of those plans were designed for a very different information architecture than we have now. They sort of had this mental model. I had a mental model that you get a novel pathogen, you get the director of the CDC to pull together the data, go out and tell Americans what the right answer is, and everybody sort of believes him or her, and then we all follow. Turns out not so much. Just not how America works or how the world works anymore. So there are some serious issues that we have got to work on understanding the information landscape, the information ecosystems in which we all live, how bad and good information spreads, and how we build up resilience against bad information. There's a whole set of other work to do. Obviously, from the biomedical side, there's a lot of work to do on building better vaccines, building mucosal vaccines. I mean, there's a lot of work to do that says if we don't do those things, we will not be adequately prepared. But I do think we're in many ways better shape than we were.
Well, you mentioned a lot of interesting things, and let's go through them, a few of them. One is disease surveillance. There's so much cool new technology out there. So what is the future, do you think? What new surveillance systems or tools do you think could be and should be most widely used, particularly to help us not only know what's spreading in the U.S., but what's spreading in other countries, sometimes when those countries' governments might not want us to know about them.
Yeah, so there's a lot of innovation, and obviously scientific innovation also needs to tie with it policy innovation, because a lot of the innovation also creates a little bit of there are really important issues to talk through, like privacy and how do we monitor a population in a way that preserves civil liberties. There's just a series of policy issues I think we still need to work through. But there's no question about it, our ability to do, and I know started with wastewater. Wastewater surveillance is extraordinary. It is very, very impressive. And, we found, even now, we're obviously tracking Mpox, formerly known as monkeypox, across the country. And we can check the wastewater of cities around the country and know if there are any cases and if there's any infection spreading in places where we're not detecting any cases. And if we see it, we can then go to those communities and really ramp up testing to try to identify people who are infected. There's all of this incredible stuff that has developed. On the global side, obviously it's really important to work with countries to develop. A lot of countries have wastewater surveillance systems, other types. Beyond wastewater, there's air surveillance systems that are developing. We have something called, I mentioned this, traveler genomic surveillance, which has got two features to it. One is when people arrive in the United States, voluntary, random sample of people, you swab their nose, and you look for pathogens. Right now we're looking mainly for SARS-CoV-2, and then you sequence it to get a sense of what's spreading around the world. And then the second is wastewater of airplanes, which is another really important source of information. So there's a lot happening, and this is just kind of in the next few years. I think over time this stuff is going to get better and better. Our ability to do surveillance is going to get dramatically better. I just want to make sure that the policy issues, the ethics issues, the social issues of having conversations with people in the general public, people understanding what is happening, that needs to follow so that we bring people along. This is not just a biology issue, but really a social one as well.
You also mentioned vaccines, and I know you're talking about vaccine platforms for all sorts of diseases. One thing I wanted to ask you about, though, is what do you think the chances are of developing a pan-coronavirus vaccine? Since coronaviruses seem to really like us,
Yep.
What are the conversations about that, and do you think enough funding is going into that right now?
Yeah, so good question. We've had 3 novel coronaviruses that have infected humans and killed people in the last 20 years, right? SARS-1, MERS, and now SARS-CoV-2. I don't think any of us think like we're done with coronaviruses. Like we're going to be dealing with more coronaviruses. So when we have thought inside the administration about where does innovation really need to go next and how do we accelerate it, and I mentioned this project earlier, Project NextGen, kind of loosely modeled after Warp Speed, but it's got some important differences from Warp Speed. One of the 3 areas of focus of NextGen is what we call sort of pan-sarbecovirus or pan-beta coronavirus vaccines. Truly pan-coronavirus vaccines are going to be hard, but most of the coronaviruses that have infected us are these subsets called sarbecoviruses. Look, there are half a dozen or so academic groups that have developed these vaccines that look very promising in the lab, look promising in non-human primates. That's great. Now we got to go to clinical trials, and we've got to accelerate it and make sure we know exactly what we're measuring. And that's what Project NextGen is going to do, is really try to drive a lot of this forward.
I wanted to ask you also about one other lesson from the pandemic, partly because it was a painful experience for everybody, I think. The quote-unquote lockdowns that were a feature of the beginning of the pandemic. What would the future look like with those? Could they be implemented again, or what should be done differently to stop or slow the spread of a highly transmissible respiratory pathogen?
Yeah, it's a good question. It's a complicated question. So let me take it apart in a few ways. First, I think we did essentially, the president at the time, Donald Trump, did a nationwide lockdown, primarily because we had such bad surveillance, such bad testing. We had no idea where the virus was spreading. We knew it was spreading in New York. We knew it was spreading in a couple of other places, but we had no idea where else it was spreading. And because of that, we had to do a nationwide lockdown. Now, here's the thing. In New York, there is no question that substantial restrictions in activity, lockdowns, saved just a tremendous number of lives. I mean, if you think about those early days, if we had kept activity going and everybody kind of functioning normally, like our healthcare systems were at the brink, and you could argue went beyond the brink. New York just would have seen many, many more deaths. Did Montana need to undergo a lockdown? It's not really at all clear. So our lack of testing and our lack of surveillance meant that the public health restrictions had to be much broader, much less discriminate than one would ideally like. You want to use those restrictions, in my mind, you want to use public health tools, what people call NPIs, non-pharmaceutical interventions. You want to use them sparingly. You want to use them in a focused way. And you're really doing it as a way to slow things down while you can develop countermeasures. Right? That's the key point. Like, one of the things people don't understand is, like, why are we doing this if with a pathogen that's going to be around forever? So one of the arguments that a lot of people who sort of in the herd immunity, remember that idea? That crowd was like, this is unstoppable, we're going to have to let it go. I'm like, it may be unstoppable. It may be that eventually most or all people get infected. But I'd much rather all that happen after we have vaccines and treatments than before we have vaccines and treatments. So the whole point of NPIs, non-pharmaceutical interventions, is to buy time. And the whole point of a really good surveillance system is it lets you figure out where do you need to intervene to buy time. I think if you do it in a more thoughtful way, you explain to people what you're doing, you can get there. There are a lot of people who have obviously a very negative reaction to it because for a lot of Americans, the experience was they were locked down and they did not see any COVID for like many, many, many months. There was none in their community. So I think that really, I think, hurt us a lot in terms of building confidence in these public health measures.
So the Rockefeller Foundation is working with other organizations to find ways to counter disinformation and misinformation. And you brought that up a few minutes ago, the challenges of communication. So what do you think governments and other official organizations should and can do to improve communication in a pandemic? And I'll just add, one of the most interesting things to me throughout the pandemic was who people were listening to and who had voices communicating. I mean, you were one, Bob Wachter, we all follow the same Twitter feeds where we're getting, Caitlin Jetelina, but we're getting more of our information than we were from the government. So how do you harness that, and also how do you counter the incredible amount of misinformation, disinformation out there?
Yeah, it's a good question. So, look, governments have certain set of challenges in how they do it. One of the things that we have been working on, and actually I think this is a really important innovation, is essentially pre-approving material to get out in the context of a misinformation event. Let me explain what I mean. So, for instance, I think when the vaccine committee of the FDA or CDC is meeting, we know the topics, obviously, of what will be discussed. If you're smart, you can figure out how will the misinformationists and the anti-vaxxers use that meeting, and what will they clip, and what is the narrative they're going to try to get out. So the standard way that governments deal with this is the meeting happens, people do that, and then we say, well, that's nonsense, that's not what the meeting discussed. And then you go through a 4-week process of developing a response, and you put out a one-page web page update 4 weeks later saying, no, that's not what happened. You've totally missed the window. Because for 4 weeks, bad information just was out there sitting. So one of the things we've been doing is thinking about what is really important, good information that needs to be coming out, and we create that information before the meeting and get it pre-approved by all the groups that need to pre-approve it. And then if you see misinformation spreading, you can get this out there immediately as a counter that says, no, you're misreading what was said, here's the real data. And so the ability of government to do that, the tension is always when you've got to go through a process, you can't circumvent the process. But there's nothing that says you can't go through the process up front. So we've been trying to do things like that to make the government more effective and responsive. But the government has only one role to play. I mean, it's really clear in this pandemic, and I think we've seen this in other health crises, that civil society organizations, what do I mean? Places like the Rockefeller Foundation, obviously universities, have a very large role to play. And what has been interesting to me is how ill-equipped most public health experts are at speaking in this information environment. So we've got to train up our public health leaders to deal with and both share good information, understand the information ecosystem they're living in. Most public health people don't get trained in that. So that's something that we've thought a lot about before I came to the White House at Brown. I think it's a really important part of public health training moving forward.
Well, you have appeared on a variety of news outlets, right? You seem to have made a point of that. So how does your messaging change when you, depending on who you're talking to? Because that's another aspect of communication.
Yeah. So before I joined the White House, I was spending more time on Newsmax than I was on MSNBC. But spending plenty of time on MSNBC and others as well, and ABC News, et cetera. So first, let's talk about why, and then the second, let's talk about your question of how does the messaging change. Why is, in my mind, very straightforward. As a public health person, you've got to reach out to people in across the spectrum. You've got to reach out to people in different communities, and different news outlets reach different communities. There is no single news source that I know of that reaches all Americans. And so you've got to go where people are, and there are liberals and conservatives who've self-sorted into different information ecosystems, and you've got to go there. And I think that is a really important part of bridge building in the United States. To the extent that public health is seen as a partisan thing, to the extent that it is seen as a enterprise of one political party, that leaves the whole country much, much worse off. And it leaves public health much worse off. So that is the reason to do it. Now, one of the things I had, as you might imagine, the questions I get on Newsmax is different than the questions I get on MSNBC. Certainly the setup of those questions is very, very different. One of the rules I had, as I would have a little team who kind of helped me with these things, was that I would argue to people, you need to be able to see me on Newsmax and MSNBC and say it's the same guy with the same message. Sometimes framed a little differently. Sometimes some of the words I use are a little bit more different, are a little different, right? So I would probably use words like freedom and personal responsibility more in some places, and kind of, our responsibility to others and working together in other places. But they're all part of that. I mean, I believe both of those. It's not like I don't believe in personal responsibility and freedom. I do. I also believe in collective responsibility that we have to our neighbors and to our friends and our families. So I would probably emphasize certain words more than others. But the message was always the same, and they were pretty predictable about how to protect yourself, vaccines, treatments, mask wearing, certainly at a time when that was really critical, et cetera.
So let's go to a couple of global questions, and then I thought maybe we may have a few minutes for questions from the audience, if you have some. The World Health Organization is negotiating a pandemic treaty, right?
Yep.
So what do you think the prospects are for such an accord, and what do you think about the proposed accord so far?
Yeah, look, it's an ongoing conversation. Like literally in the last 24 hours, there have been updated drafts circulating around. So I think there is no, I don't want to comment on the latest draft. What I will say is a couple of things. One is, I think from a U.S. government point of view, and certainly consistent with my own personal views, if you've known me before I joined the administration, is I think kind of more global coordination, global solidarity around health security issues is just a fundamentally good thing. The question is, how far can a single pandemic instrument really push that? And I think there are clearly areas where there's going to be agreement. But it is right now, I would say, and literally in the last 24, 48 hours, a source of a lot of kind of active debate, both inside the administration, but across the world. And right now, because it's the World Health Assembly is happening, and we're seeing efforts. But it gets to a slightly bigger point, though, which is, I think, my view early on, and I think this administration, when it came in, really focused on this, is there is no domestic-only solution to global pandemic problems, right? Like you cannot, basically every major variant we were hit with came from somewhere else. Obviously, the global toll of inadequate vaccines early is very, very large. We think 20, 25 million people probably died of this virus if you look at excess mortality, not just official deaths. And that's why early on in this administration, but again, consistent with my views, like we worked very closely with Gavi and COVAX to try to get vaccines out. Could have just done everything by ourselves directly as bilateral, but I think there was a belief that these multilateral institutions need to be supported by governments like the United States, and that we want to build them up and make them even more effective. So I think engaging in these multilateral institutions, which is a little different than our predecessors, did in the prior administration. These multilateral institutions are very, very important for kind of global effectiveness, and I think this administration certainly has been very supportive of that.
Let's see, do we have any questions from the audience? Anyone would like? Yes.
Hi, great presentation, thank you. My question is, 3 years ago, I never could have imagined that we would reach a point where even after so many people died, early in the pandemic, that there would be such resistance to the idea that this was actually something real. So both from a partisan perspective, viewing a healthcare crisis through the lens of, the partisan divide, and also just the galvanization of the anti-vaxxers, the people that basically at the end of the pandemic, if you go down those rabbit holes, what they say is, see, you were vaccinated 5 times and you still got it. So it's heartening to know that we're in a position where we're actually better positioned to address the next pandemic. But how great a challenge is that, both the partisan challenge as well as the general sort of noise about how this is all a big joke and a hoax?
There are several pieces to that question. Let me see if I can take them on. One is I worry a lot about the spillover of the anti-COVID vaccine to anti-vaccine to anti-medical science to anti-science more broadly. Like that is a slippery slope that is actually both very steep and very short. And we're seeing people get there very quickly, right? Because a lot of the counter arguments I have tried, like 98% of doctors got vaccinated. And they're like, oh, the doctors are all corrupt. I'm like, the doctors are all corrupt? Like, my God, like, how did we get there that fast, right? Well, the nurses too. Like, holy cow. Again, doctors and nurses largely very trusted in America. But there has been this kind of that's a real problem. Look, there's real debate about how to characterize this. I have believed, and I still believe, that this is less of a partisan problem, even though you may feel like you hear more from one group or another, and just a kind of think of it this way. 3 years ago, most Americans woke up at some point in March or April and said, "Oh my God, I don't understand the world I'm living in," right? And had very large information needs. They had an information appetite for just somebody explain the world to me. And I would argue that we in public health as a community, many of us tried, the government, et cetera, did not do an adequate job of filling that information need. And that set us up for people sharing misinformation. At this point, I see lots of bad information happening across the political spectrum. It's actually interesting to me how much, there's this whole, on the anti-vax side, died suddenly thing that people, I don't know if you were seeing this, anybody who dies of anything, they're the anti-vaxxers are it was the vaccine. No, the guy got in a car accident. That happens. After he got vaccinated 6 months ago. I'm okay. But then the flip side is you're seeing from another extremist group, kind of on another part of the political spectrum, saying COVID is just killing Americans left and right. Long COVID is. Long COVID is a real problem. But it is also kind of being weaponized to say, this person died suddenly. It must have been the COVID they got 9 months ago. And so that is a real problem that in my mind is less partisan and more about really much more proactive, effective engagement with people and helping people understand the world we're in.
We have just a couple minutes left, so is there any other question from the audience? Just a quick question? Yes, go ahead.
Yeah, thanks very much for this. Can folks hear me? Going back to sort of the comments you were making about globalization, about the different kinds of diseases that are coming down the pike because of climate change. Well, how can we get ahead of that from a communication standpoint? We know that climate change is already a challenging topic to talk about, not just in the United States, right? Around the world as well, because it has implications for different folks in power. So how can we start communicating, start building that culture around being able to understand the effects that climate change is having from a public health standpoint, not just in the US, but more broadly? And I guess this question has a lot of different forks, but I guess one of them is not just as a government or as an institution like Rockefeller, but across sort of all the different roles that everyone plays.
Yeah. One quick story, and then I think a more direct answer to your question. I think it was 2018, the House Ways and Means Committee had its first sort of hearing on climate and health. No, I'm sorry, not climate, just on climate change. And there were 5 people. I was the only health expert in the room. And the others were all energy experts and scientists who studied climate change. And 80% of the questions came to me. I thought that was super interesting. Not because I was the most interesting person in the room, by far not. It's because health is the angle by which people understand climate change. And so no one understands or cares about 1.5 degrees centigrade. We all do because we understand that that's actually a real problem, let alone 2 or 4 degrees. Most people think 1.5 degrees centigrade, is that the same as Fahrenheit? And so you're saying it's going to be instead of 75, it'll be 78. I don't know, that sounds fine. I can live with that, right? And if you're in the more colder climates, you're actually maybe nicer winters. No one, again, just hard to motivate people. Also hard to motivate people by sea level rises, and unless you live in Miami Beach, and your real estate's going to be hit. And the reason why I think people understand the health issues is because climate change, at least for me as a public health person, I'm not an energy expert, it's more asthma in kids, it's more strokes in adults, it's more famines, it's more migration, it's more heat waves, it's more pandemics, and all of a sudden it's a world that is far less healthy to live in, where we're all going to be facing those challenges. And to the extent that we can talk about it in that way, I think it feels much more tractable to people. That's why a lot of us often say, health is the human face of climate change. It is how you capture people. And so at least for me, it's easy because I'm not a climate scientist or an energy expert. I just talk about it as a health issue. I think that helps.
That's a couple of daunting challenges for us to end on. Dr. Ashish Jha, thank you so much for being with us today.